Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from Axum Therapeutics Incorporated.
Hello, I'm Joseph Goldberg, clinical professor of psychiatry at the Icahn School of Medicine at Mount Sinai in New York. Welcome to this program entitled The Mechanisms Behind Rapid-Acting Treatments for Major Depressive Disorder. By the end of this lecture, I hope you'll be able to describe glutamatergic mechanisms underlying rapid antidepressant effects, learn about efficacy and onset of action of S-ketamine and dextromethorphan bupropion, recognize key safety considerations, and select appropriate patients for treatment. This program will limit its scope to the currently FDA-approved therapies for major depressive disorder qualified as fast-acting. So let's get some background. About a third to half of patients with major depression actually have treatment-resistant depression. The FDA defines treatment-resistant depression, or TRD, as an inadequate response to at least 2 antidepressant medications, despite adequacy of the treatment trial and proper adherence to the treatment. So some shortcomings, limitations to think about with traditional monoaminergic antidepressants. Slow to start. We think about delayed onsets of at least several weeks, 4 to 6 weeks, sometimes even longer in hard-to-treat forms of depression. And indeed, they have limited efficacy in difficult-to-treat or treatment-resistant forms of major depression. Early improvement of depressive symptoms, at least an initial inkling, is something we'd like to see at least within the first couple of weeks of treatment. It's not a bad predictor of eventual response or remission if we can see at least a 20% improvement by the first couple of weeks of treatment. If we don't, it doesn't mean we're not going to see success, but if we do, we're that much more optimistic. Let's talk about some of the unmet needs in major depressive disorder. Perhaps first and foremost, suicide risk and functional impairment are among the most compelling adverse consequences of depression. They demand faster treatments. And yet the delayed, or in many cases poor, response to current antidepressants makes us think there may well be other neurotransmitters that are involved in the pathophysiology of depression than those that are accounted for by traditional monoamine theory of depression, which postulates reduced levels or functional efficiency of catecholamines, indolamines, catecholamines such as dopamine, norepinephrine, and dolamines such as serotonin. So let me ask you this question. Does your current treatment paradigm allow you to treat patients who may be experiencing residual symptoms, such as anhedonia, can't feel pleasure, fatigue, lethargy, cognitive impairment, or anxiety? Let's talk about a paradigm shift, moving away from monoamines, and as we talk about now, rapid-acting treatments for depression. So a latest class of medication, these fast-acting antidepressants, are molecules that have been observed to help alleviate symptoms of depression, sometimes within hours or days of initial treatment initiation. Here's one example. So the drug S-ketamine, that's the S-enantiomer of ketamine, as an augmentation of a new monoaminergic antidepressant as compared to the monoaminergic antidepressant plus a placebo, was initially studied over several weeks. And so we can see in this graphic that week by week, the likelihood of seeing improvement is substantially greater with adjunctive S-ketamine added to the monoaminergic antidepressant as compared to the monoaminergic new antidepressant that was begun alone, with improvement in depression symptoms evident by as early as day 2. So how do we think about beyond monoamines? And let's take this back to glutamate, the most abundant excitatory neurotransmitter in the mammalian brain, very heavily implicated and involved in synaptic plasticity, neuroprotection, neurogenesis, strengthening nerve cells to make connections stronger. We have these excitatory glutamatergic projections coming from our cortex, down into subcortical areas in the brain, limbic system, thalamus, nucleus accumbens, critical areas that are involved in emotion regulation and processing. So these excitatory glutamate pathways, in some ways, are the overseers of subcortical functions that can include monoaminergic pathways and possibly others. This is like the mastermind of the brain, if we think about it, and yet it's only been fairly recently that we've turned our attention to ways of modulating or tweaking the glutamate system by targeting our medications to specific domains involved in glutamate transmission. Enter the role of ionotropic glutamate receptors, as we talked about just a bit before, and NMDA receptors and AMPA receptors in particular. NMDA receptors are a type of ionotropic or ungated glutamate receptor that regulates the protection of nerve cells from oxidative stress. It enhances neuroprotection, increases synaptogenesis. If you could modulate glutamate by tweaking these ionotropic glutamate receptors, such as NMDA, and AMPA, we can actually turn on genes that protect nerve cells from damage and shrink the nerve cell connections. So let's talk now about FDA-approved fast-acting antidepressants. S-ketamine nasal spray was FDA-approved in 2019. The drug dextromethorphan bupropion oral combination was approved in 2022, and these two constitute the first non-monoaminergic antidepressants approved by the FDA for major depressive disorder. Let's now turn to a bit of an overview of mechanisms of action in a bit more depth with both of these glutamatergic modulating agents.
Glutamatergic receptors are the primary receptors for glutamate, the brain's main excitatory neurotransmitter, and they play a key role in learning, memory, and synaptic plasticity. They fall into two main categories, ionotropic and metabotropic receptors. Ionotropic receptors, NMDA, AMPA, and kainate, are ligand-gated ion channels that produce rapid excitatory signaling by allowing ions such as sodium and calcium to enter neurons. In contrast, metabotropic glutamate receptors, or mGluRs, are G-protein-coupled receptors that modulate neuronal activity more slowly through intracellular signaling pathways. Together, these receptor systems regulate synaptic strength, neural communication, and processes essential for cognition and mood. The mechanism of esketamine in the treatment of MDD is unclear. Esketamine is the S enantiomer of ketamine, meaning it is a mirror image form of the ketamine molecule with greater affinity for its primary target in the brain. Structurally, it belongs to the aryl cyclohexylamine class of compounds. Its therapeutic effects are primarily mediated through non-competitive antagonism of NMDA receptors, a subtype of glutamatergic receptor. By blocking NMDA receptors on inhibitory GABA interneurons, esketamine increases downstream glutamate release, which then stimulates AMPA receptors and activates signaling pathways that enhance synaptic plasticity and connectivity. This activation triggers a downstream cascade, including increased synaptogenesis, stimulation of the mTORC1 pathway, promoting neuroplasticity and the creation of new synaptic connections. BDNF release, elevated brain-derived neurotrophic factor BDNF levels, which repair and strengthen neural pathways. Monoaminergic modulation, enhanced dopamine and serotonin release, particularly in the prefrontal cortex. The mechanism of dextromethorphan bupropion in the treatment of MDD is unclear. Dextromethorphan bupropion is a combination therapy that pairs two well-known agents with complementary mechanisms. Dextromethorphan, a morphin derivative structurally related to codeine, acts as a non-competitive antagonist of NMDA receptors, reducing excessive glutamatergic signaling. It also functions as an agonist at sigma-1 receptors, intracellular chaperone proteins that modulate neuronal signaling, neuroplasticity, and stress responses. Bupropion inhibits the reuptake of norepinephrine and dopamine, and also serves to inhibit CYP2D6, slowing the metabolism of dextromethorphan and prolonging its activity. Together, these actions enhance glutamatergic modulation and monoaminergic signaling, which are believed to contribute to the medication's antidepressant effects.
Let's talk about rapid-acting antidepressants in terms of efficacy. So if we put side by side esketamine and dextromethorphan bupropion, they share in common some properties, NMDA receptor antagonism. Dextromethorphan bupropion seems to have this unique component involving sigma-1 receptors, not quite as clear in the case of esketamine. The routes of administration differ, so esketamine is an intranasal insufflation, whereas dextromethorphan bupropion is an oral administration. And there is a REMS program that requires supervised monitoring for a couple of hours after administration of esketamine. It can't be performed at home. It has the potential for causing a dissociative effect as well as a modest potential to raise blood pressure that requires in-office monitoring. That's not the case with dextromethorphan bupropion. So here are the studies that demonstrated efficacy in terms of the FDA registration trials, named as the TRANSFORM and ASPIRE studies. So the first of these, the TRANSFORM studies, looked at the efficacy of esketamine in combination with a newly begun oral antidepressant as compared to the newly begun oral antidepressant plus a placebo. In short-term trials, looking to see if there was a greater degree of improvement in overall depression symptoms. Those were measured using a standard scale called the MADRS scale, the Montgomery-Åsberg Depression Scale. And the focus here was on patients with major depressive disorder, non-psychotic in the short term. Another set of studies called the TRANSFORM-3 studies looked at older adult patients with major depression over age 65, slightly lower dosing of esketamine down to 28 milligrams a day, up to 84 milligrams. And insufflations occurred in all of these studies twice a week for the first month. Looking for sustained benefits in the maintenance dosing phase with the TRANSFORM studies. So first, looking in the non-elderly population from the TRANSFORM studies, we see a statistically significantly greater advantage on various measures of outcome in terms of MADRS scores and depression symptom improvement over the course of time with esketamine augmentation of the new antidepressant as compared to the new antidepressant alone. In the older adult study, the TRANSFORM-3 study, statistical significance was just missed by a hair, a p of 0.059, so numerically very consistent with what was seen in the non-elderly population. All of these studies collectively show a strong signal for rapid onset and robust efficacy of esketamine in major depression. From the ASPIRE studies, we're now looking in major depressive disorder patients who were deemed to have imminent risk for suicide. So both of these studies actually showed not only rapid improvement in MADRS symptoms, both at 4 hours as well as 24 hours after the first dose, and then consistency over 4 weeks. But moreover, in this very high-risk population with suicidal ideation, we saw a significant improvement. This has implications in terms of speed of onset, potential implications about treatment setting, and about really what happens in the very first day of treatment for a severe form of major depression. Now, if we take a post-hoc analysis of the pooled ASPIRE 1 and 2 trials, we can ask questions about remission and consistency of remission. For patients who did achieve remission during the double-blind phase, we see various measures of sustained remission for the weeks following the initial acute resolution of symptoms and the depressive syndrome as compared to just standard of care treatment, which was the antidepressant plus placebo. How about monotherapy patients with treatment-resistant depression? So more recently, the FDA approved these data with esketamine not as an augmentation to a new antidepressant, but all by itself as monotherapy. Efficacy evaluated over 4 weeks as compared to placebo alone. Dosing of esketamine 56 milligrams initially twice a week, then increased to 84 milligrams twice a week as compared to placebo after a 2-week initial washout or longer off of initial antidepressants. And what we see here is a remarkable, swift improvement in depression symptoms at the very first data points, within the first week, certainly, if not the first few days, at both the 56 and 84 milligram doses of esketamine. Again, improvement visible within 24 hours and the effect maintained through 28 days of the double-blind phase. Now, a phase 3 clinical trial known as the Gemini trial further looked at dextromethorphan bupropion and its efficacy over the course of time. These are patients who are receiving the fixed dose of either 45 milligrams worth of dextromethorphan plus 105 milligrams worth of bupropion SR Initially once a day for the first 3 days, then twice a day thereafter. And now we're looking at changes in MADRS scores, same as with the esketamine studies, over the next 6 weeks. We turn to outcome in these phase 3 studies from Gemini. Once again, we see rapid onset, that is improvement in depression symptoms evident as early as week 1. Superior efficacy at week 6. The dextromethorphan bupropion patients had an overall MADRS depression rating that was significantly higher than was seen with placebo. About 40% of patients overall achieved remission by week 6. That was significantly greater than the roughly 17% of patients in the placebo group. If we pull out the items from the MADRS scale that evaluate anhedonia, the inability to feel pleasure, we also see significant improvement in depression symptoms overall and improvement in anhedonia symptoms, often again in the first week. So now let's turn to a phase 3 study, an open-label trial with dextromethorphan bupropion known as the COMET trial. It's a long-term open-label efficacy and safety study in adults with DSM-5 major depressive disorder without psychotic features. The total enrollment of the study was 865 participants, comprising 265 patients with prior control trials with dextromethorphan bupropion, as well as 611 new patients. Mean MADRS depression scores were compared to baseline. This was seen over the course of 6 months, and we see improvement over the course of time that was consistent over the clinical trial. In particular, clinical response and remission rates were also maintained over the 12-month period. So at 6 weeks, 73% of study patients responded to treatment, an increase to 85% and 83% at 6 and 12 months, respectively, and likewise remission occurred in 53% of patients at 6 weeks. That increased to 68% at 6 months and was maintained at 12 months. Let's turn now and talk about safety and tolerability with rapid-acting antidepressant drugs. So first, looking at esketamine, the most common adverse effects that were seen in clinical trials with esketamine for major depression were dizziness, nausea, sedation, and blood pressure elevation, typically transient. Boxed warnings with esketamine include the potential for sedation and dissociation, the potential for respiratory depression, and the potential for misuse and abuse. Also, any molecule that's identified as having antidepressant properties by the FDA includes a boxed warning for an increased risk for suicidal thoughts or behaviors, strictly in people under age 24. There's also a precaution about the use of esketamine with respect to pregnancy, a potential for embryo-fetal toxicity. A collective review of 14 articles examined neurocognitive functioning in patients with major depression taking esketamine. There was no signal to suggest neurocognitive toxicity. That's sometimes a concern when ketamine is actually used in non-treatment settings in terms of its potential adverse effects as a substance of abuse. So some reassuring data in terms of safety from the clinical trials. In terms of the safety profile for dextromethorphan bupropion, the most common adverse effect seen was dizziness in about 17% of patients, as well as potential dry mouth, nausea, insomnia, and the potential for increased blood pressure, which is thought to be related to bupropion. That's one of the reasons for the initial dosing escalation. As with all antidepressants, the box warning for increased suicidal thoughts or behaviors in younger patients. And then from bupropion, increased risk of seizures is a concern. Dextromethorphan can potentially be associated with serotonin syndrome if combined with other serotonergic drugs. There's the potential for abuse from dextromethorphan unto itself, although importantly, dextromethorphan bupropion did not produce dissociative effects because you're blocking the metabolism of dextromethorphan, and it's not a controlled substance. And once again, the potential for embryo-fetal toxicity. Think about this. When a patient shows no meaningful or even partial improvement on an antidepressant, what are your thoughts about whether to discontinue or deprescribe that medication as opposed to continuing it out of hope, faith, habit, uncertainty, fear of destabilization? It's actually a very critical decision point for all practitioners, all prescribers to think about at what point do we decide continuation of an existing intervention may not be successful. All right, so let's talk about a clinical decision framework. We want to ask if the patient with major depression has treatment-resistant depression or not. Is there a particularly compelling need for a rapid response, such as very high severity, grave functional impairment, suicidal thoughts or behaviors? Are there medical comorbidities present, and how do those figure in? And lastly, what's the patient's own preference in terms of what kind of treatment they want to have? So here's a flow diagram that gives us a bit of a sense of how to think about these things. So starting with a patient with major depressive disorder who has not responded to prior antidepressant, that by definition would make the FDA's definition of treatment-resistant depression. If suicidality is present, we might want to think about esketamine. Data that we saw a moment earlier speaks to the efficacy of esketamine in reducing depression symptoms, even in the setting of significant suicidal ideation. Do you have to do in-office interventions for the treatment? There's no driving afterwards. Patient has to follow the REMS protocol. If the patient doesn't have treatment-resistant depression, if they've not responded to 2 prior antidepressants, that is treatment-resistant depression. If it's a little more ambiguous, if they've not had adequate trials of prior antidepressants, but they're still significantly depressed, or there's interest in looking at a non-monoaminergic approach, we might think about dextromethorphan bupropion. Again, oral, daily medication, twice daily dosing. At home, does not require in-office visits. There's no REMS protocol in place. Do want to keep an eye on blood pressure because of the bupropion component, but it's not the same level of intensity of monitoring as occurs with intranasal esketamine. And then we want to look for any potential contraindications to either treatment. Relatively speaking, in the case of esketamine, poorly controlled or uncontrolled hypertension, a history of a brain aneurysm, or a history of increased intracranial pressure and intracranial hemorrhage would be relative contraindications for esketamine. In the case of bupropion, dextromethorphan, history of a seizure disorder because of bupropion's risk for lowering the seizure threshold. Similarly, the history of an eating disorder, especially bulimia, purging, could affect electrolytes, and that could lead to lowering the seizure threshold. And also, if patients happen to be taking a monoamine oxidase inhibitor, that's a contraindication to dextromethorphan because of the risk of serotonin syndrome. So after screening for contraindications, we can then talk about starting treatment. So in the case of intranasal esketamine, patients do have to be treated in office. There's a 2-hour monitoring period afterwards, dextromethorphan bupropion at home, but some monitoring of blood pressure and monitoring for side effects. And in both cases, we're looking for response, needless to say. It's useful to have some measurement-based tracking tools, such as the PHQ-9, to get some quantitative measure or impression of are things improving or not, over what time frame. If we see improvement in the expected time period, we continue the treatment, we continue to monitor side effects, and we watch for signs of relapse. So let's finish with just a case study. Let's imagine Ms. L, a 42-year-old woman, high school teacher, a past psychiatric history of recurrent major depressive disorder. She has well-controlled hypothyroidism. She's been on a number of medicines that have not been efficacious for her, or at least not fully so. Sertraline, adequately dosed, partial response. Venlafaxine XR, a serotonin norepinephrine reuptake inhibitor, minimal response. Bupropion augmentation of those agents did not help. In fact, may have had some correspondence with worsening of anxiety and insomnia. And then cognitive behavioral therapy is an ongoing adjunctive treatment. So Ms. L presents with a 3-month severe depressive episode. It's characterized by persistent depressed mood, anhedonia, marked psychomotor slowing, insomnia involving early morning awakening, poor concentration, feelings of worthlessness, passive suicidal thoughts. I don't want to wake up in the morning. Doesn't necessarily have a plan or intend to act on those thoughts, but they're present. And on a patient-administered rating scale of symptom severity, known as the PHQ-9, she scores a 22. That's a fairly severe level of depression. That's about comparable to a mid-score in the 30s on the MADRS scale. She's missed several weeks of work. She's having some functional impairment. She's having a hard time functioning at home. She's very distressed about how long it takes for antidepressants to work. Think about this. If someone's undergone several trials with conventional antidepressants and they're not getting better, it becomes a bit harder to maintain a sense of morale and optimism. She says, I can't wait another 2 months to feel better. And I said, to hope that she might feel better. So she meets criteria for major depressive disorder, severe, recurrent, without psychotic features. This is treatment-resistant depression by the FDA definition. She has high functional impairment, the passive suicidal thoughts, no history of psychosis, no history of bipolar disorder, no substance use disorder, no contraindications to one of the rapid-acting agents. She's normotensive from a blood pressure standpoint, no uncontrolled cardiovascular disease, no history of a dissociative disorder. Traditional antidepressants do take a number of weeks to work, but even more importantly, after several non-successful treatments, the probability and likelihood of a traditional monoaminergic antidepressant working statistically becomes less and less and less with each successive trial. So all of these factors collectively make Ms. L a strong candidate for a rapid-acting antidepressant with a novel mechanism of action. We've talked about two today, intranasal esketamine and oral dextromethorphan bupropion. So a treatment plan for Ms. L, she can certainly continue on her venlafaxine XR, and we can augment her treatment as a next step. That could either be with adjunctive intranasal esketamine. It is FDA approved both as monotherapy and adjunctive treatment, or we could also augment her existing venlafaxine XR with oral dextromethorphan bupropion. Oral dosing might hope to see a rapid improvement within 1 week's time and somewhat less clinical burden in terms of at-home administration, and there's no need for the monitoring after the acute treatment occurs. Though we do want to certainly monitor Ms. L's clinical progress over time. So she should be seen on at least a weekly basis. Measurement-based care using a scale such as the PHQ-9 is a really good way to quantitatively track success and outcome. Monitoring blood pressure, she is on agents that can affect blood pressure. Assess for no dissociation, sedation, potential misuse, and keeping a close watch on her suicide risk given the severity of this depression with any treatment that she's getting. In terms of her clinical course for Ms. L, we see improvement in symptoms within 48 hours, a reduction in the intensity and severity of suicidal thinking, better sleep, fog lifting over the course of 2 weeks. Her MADRS scale score is nearly halved from 34 to 18. That's very optimistic, bodes. She can start to return to work on a part-time basis, is able to continue in her adjunctive cognitive therapy, and by 6 weeks, which would constitute the adequate trial, we've seen a sustained response and now transition her to a maintenance phase of treatment. So to conclude, both of the treatments we've talked about today, dextromethorphan bupropion and intranasal esketamine, represent departures and advances in some respects from the monoaminergic approach toward treatment of major depression. We've seen a rapid symptom improvement. That's a possibility with both of these agents. Important to maintain careful selection of patients based on their clinical criteria, to monitor patient safety, and to know that we can now expand our pharmacopoeia options for hard-to-treat forms of depression with these new advances. I hope you found this presentation useful. Thank you for joining and listening today, and please continue on to complete your evaluations for this activity.